So I'm going to get to some specific questions now. There's a question that came in particular to headache. So this patient was a young patient, age 5. They had typical Chiari headaches and then had a decompression, but now they're getting frontal headaches. So I guess, is that something that's common to maybe after decompression, the Chiari headache goes away at the back of the head, but now we're getting these frontal headaches that have nothing necessarily to do with the Chiari maybe? What could possibly be the cause of something like that? And how do you approach it?
If the person has already had a decompression and develops frontal or temporal or global headaches, I'd be concerned about hydrocephalus. And, only about 3 to 5% of our Chiari patients end up developing hydrocephalus to the point that they require a shunt. But we see a lot more of them than that who seem to have this elevated intracranial pressure that is it's transient. It goes on for weeks to months after decompression, and then seems to settle down with a little steroids, maybe diamoxacetazolamide or Lasix for 3 months or 6 months, and then we're usually able to wean that off. Now, a 5-year-old is not going to be able to really describe it that much, but headaches in a 5-year-old are very unusual anyway. Typically, kids will keep trying to just keep going, keep playing, keep running around. They don't want to be told to come inside and lie down. They don't want to stop what they're doing. So if they tell you they have a headache, it's probably a horrible headache. It's not a mild headache. If they're having headaches once or twice a week and they're complaining about it, they're really having headaches every day, and it's just severe once or twice a week. So I take those very seriously, and I would be concerned about hydrocephalus in that child.
Okay. A question came up in the chat that's sort of related. Do you recommend decompressing young kids? So I guess age 5 or maybe a little plus or minus. And how does decompression in those young kids affect the outcomes? Oh, and this is always an important question. Everyone always asks this. Do you open the dura or do you not? Loaded, I know. But
I think full hour. Okay.
yeah.
With little kids, if they are symptomatic, then I decompress them. I consider decompressing them just as I would anyone else. I have a much lower threshold for symptomatic in a young child because they just don't complain. For example, a 3-year-old is not going to tell you I have numbness and tingling in my hands, but she might tell you it feels like there are bugs crawling on my scalp all the time. Or you might just see her scratching her legs all the time and scratching her feet and not really saying much at all. And those are paresthesias. So typically, if young children are consistently complaining about headaches, neck pain, funny feelings in their arms or legs or scalp, then and MRI shows Chiari malformation, then I would go ahead and decompress it. And they do very well. That was the next part of it. We recently did a study looking at Chiari malformation and decompressions and stratified them by age groups, 0 to 17, 18 to 40, and then over 40. And over 40 group really includes people up to 60, 70, 80 years old. What we found was that the kids do much better than the other groups as far as outcome and relief of symptoms, and also improvement in non-headache symptoms like weakness and clumsiness and things like that. Interestingly enough, the older patients did not have more complications, so the outcomes were good across the board. The older people had as good outcomes as the 19 to 40-year-old group without an increase in complications.
That's actually jogging my memory. Have you given this talk before? I think you have.
Yes. I did.
Okay.
This is our paper from 2017 that was published in World Neurosurgery.
Yes. All right. I will include a link to that maybe in the chat because I remember that one. But the last question, which I noticed you tried to dodge, is do you open the dura or not?
I always open the dura. I have over the last 30 years, seen about 5 cases of tumors that were in the fourth ventricle, either choroid plexus papillomas or ependymomas that would not have been found if we hadn't opened the dura. My colleague Arnold Menezes in Iowa has also talked about other problems in the fourth ventricle. Arachnoid veils, which are membranes blocking the fourth ventricle. Small adhesions, even just a network of adhesions, which if you can picture spider web, it's pretty fine, not that much, but if you really wrap an area in spider web, then you have this thick membrane, and a lot of the time that's what we see. I have recently found cysts in the fourth ventricle that were compressed. So none of this shows on MRI because the tonsils are crowding everything. And typically we don't give gadolinium or contrast when we get an MRI because we're not looking for a tumor. So all you just see is this sort of heterogeneous or homogeneous tissue in the fourth ventricle, which you assume is the tonsils. So I always open the fourth ventricle, partly open the dura to look at the fourth ventricle, partly because there can be other anatomic areas of blockage there, but also because I always resect or shrink the tonsils. The cerebellar tonsils are the bottom of the cerebellum that goes down into the spine. Doesn't have any function that we know of, and more often than not, it just goes down and plugs the flow of fluid again between the brain and the spine. And it typically will be worse because now you have the post-operative scarring that happens plus the crowding. So yes, I always open the dura.
Can you speak a little bit to what the risks are of not opening the dura, or I guess what the risks are of opening it versus not opening it? Because I know I'm sure you know about, I think it's Dr. Limbrick is doing that PFD study to kind of figure out if one's better than the other, because right now we don't know. So maybe just talk a little bit about why some people do or don't.
So 70% of neurosurgeons do something to the cerebellar tonsils, either coagulate them or shrink them. You can't do that without opening the dura. So you can extrapolate that at least 70% of people open the dura routinely. That said, any way of doing Chiari decompression has helped people, right? We don't do an operation that doesn't help. So everybody has benefited either from very small exposures, from opening the dura, from not opening the dura, from doing nothing to the tonsils. There's no wrong or right way across the board. About 70 to 80% of the time, only opening the bone does result in a good outcome. But that leaves 20 to 30% of people who will have to have a reoperation, and I don't find that acceptable. So personally, I want to do everything that will guarantee a good outcome as much as possible. So I always open the dura. Recently, last year, we looked at our results in patients who've had surgeries before. And what I was interested in is twofold. How do they do? Because the number one question people ask if you're going to do surgery again, how do I know I won't have to keep having this surgery? If it was scar tissue that formed, everything scarred down, what's to keep it from scarring down again? So that was the question. Do people continue to have problems? And then the second question is there anything we can see that most of the time or more frequently accounts for this person having to come back? So I looked at graft types. I looked at what was done at surgery. I looked at, the size of exposure, whether the dura was opened, complications afterward. And what I found is, first of all, out of 80 patients over 17 years, only none of them had to have surgery again. So I had done the previous surgery in 2 of those 80, but then I had done all of the reoperations. Nobody had to have another operation. So it's not true that they will just scar down again. So it is worth doing. But then the second part of it, the most common finding was that the tonsils were still in.
Mhm. Yeah.
So essentially, if you leave, this tissue still blocking the fourth ventricle, still coming down into the foramen magnum and down into the spine, then you're more likely to have to come back. But
Mm.
that's not 100%.